All right. Well, shifting gears. I know renal is what many of you guys are here for and mostly interested in, but we have lots of good renal sessions coming up later in the week, and I hope we continue to have these nice discussions. I'm going to shift gears a little bit, going back to our 101 material here, and there'll be a talk later about ciliopathies. And on Thursday, we have a nice pulmonary session. So I thought I'd set the table here and just discuss a little bit about ultrastructure of the lung and some of the disease processes that our EM lab gets involved with these cases. We're going to start here after we receive a distal lung biopsy. There's essentially three anatomic compartments, kind of like we started off with the kidney. And we're just going to look at these in order. There's large air spaces in the center there, referred to as alveoli. And then numerous small blood vessels, small little capillaries. Here you can see red blood cells in these blood vessels. And then at what is normally a very inconspicuous thin interstitium containing a very delicate connective tissue stroma. And then the types of cells that we encounter, the lung's primary function, of course, is the oxygen carbon dioxide exchange that occurs between the alveoli and the capillaries and the vascular compartments. And that occurs first across a very thin endothelial lining of the capillaries, then across the very delicate basement membrane, and then the thin cytoplasm of the type 1 pneumocytes. So these type 1 pneumocytes are lining the alveolar space, and they have a very long attenuated cytoplasm that covers that basement membrane there. And then present in smaller numbers are the type 2 pneumocytes. Here that they produced a surfactant that keeps the opposing alveolar walls from sticking together. It aids in the oxygen exchange across that basement membrane. And the type 1 pneumocytes outnumber the type 2 cells by about 20 to 1. So we don't see nearly as many of the type 2 cells. But they're easy to recognize when they see them because of the surfactant granules inside. And then in cases of lung injury, those type 2 pneumocytes can multiply and proliferate. You can get many more type 2 cells. This would be the cytoplasm of a type 2 pneumocyte with the surfactant granules. We'll talk a little bit more about those later, but that's typical lamellar bodies containing the surfactant. And then just like the type 2 cells can increase in quantity, so can this third cell type called the alveolar macrophage. Just like the Kupffer cells in the liver, this is just a resident histiocyte for the lung. It's there to kind of gobble up any kind of pathogens or anything that might be in the lung. And questions sometimes arise about what material is inside these macrophages. And electron microscopy can help with that. EM is a little more sensitive than the Prussian blue reaction to identify iron accumulation in these alveolar macrophages. And likewise, it's a little bit more sensitive than oil red O stain to identify the lipid-laden macrophages that are characteristic of aspiration pneumonia. And sometimes you can even make out some of the organic material that's been phagocytized by these macrophages. And then because of electron microscopy, we may hear a little bit more about this later in the week, is we're not very compromised by very small samples. That's kind of what we do, right? And so, which makes EM a good candidate for BAL specimens. And in this instance, it was to confirm a suspected case of amiodarone toxicity. And in here, I just wanted to point out this asterisk that's up here next to a very, very prominent Golgi complex, which kind of provides an indication that this storage material is being synthesized or produced rather than being phagocytized by the cells. And then questions may come up as to what non-cellular material is present within the alveolar spaces. In this case, this is fibrin. We could go up to higher magnification. You'd be able to see the fine structure of fibrin, but fibrin can accumulate there. But frequently, the concern relates to the possibility of pulmonary alveolar proteinosis, or PAP. And in this situation, it's a condition in which there's an abnormal accumulation of surfactant. So this is all surfactant, abnormal surfactant that's accumulating out in the alveolar spaces. This can occur in a primary form or secondarily in the setting of different kinds of infections, malignancies, environmental exposures to certain toxins can cause that. But it's something to recognize in these lung biopsy samples. Electron microscopy can be of assistance in identifying conditions of surfactant deficiencies. And so we'll look at a few images of that, and then with a kind of a caveat at the end. But there's sort of surfactant deficiency. Well, back up a little bit. The lamellar bodies, these are specialized little lysosomal derived storage organelles for surfactant, synthesized there by the type 2 pneumocytes, packaged up into these lamellar bodies that are then secreted into the alveolar spaces. They're made up of about 90% phospholipid, 10% protein, line that alveolar surface, again, kind of lowers the surface tension, and the surfactant protein then forms the tubular myelin within the alveoli. There's just a few surfactant deficiencies that we've identified, and the ones here with the red arrows have what many say are specific EM findings for those particular mutations. So you have the surfactant protein B, surfactant protein C, and the ABCA3 mutations are all types of surfactant disorders that we can recognize. I'm going to show you a few images. The serious problems can arise when the surfactant production is either deficient or aberrant in some way. But here you see some real gnarly little dense surfactant granules. They don't have that nice lamellation, that separation of the layers. Here's another example of one that looks like that. Here's some other examples. So these are just very degenerate looking. They've lost all of that lamellation. They're kind of large, degenerate looking. Here's some extremely large surfactant granules here, almost about a quarter the size of the nucleus. These are abnormal as well. And then you can get what they call kind of a fried egg morphology, where you have a condensation of those proteins in the center. It's been reported, and I've even given talks showing what each one of these specific mutations is associated with. But I would say for a beginner, especially if you don't have a lot of experience, the most important thing is just to be able to recognize if they're normal or abnormal, because there's a lot of overlap. And we've had cases where what we see looked like, let's say, the ABCA3 mutation, but turns out whenever we say these surfactant granules are abnormal and they get genetic testing, it turns out to be a completely different one, SPB mutation or something like that. So there's a lot of overlap. And in our reports now, we don't really specify or speculate on what exactly the surfactant deficiency might be. But just getting the workup going in the right direction and saying we're seeing a lot of abnormal surfactant granules, and that's something that a pulmonologist or pediatric pulmonology pathologist can kind of identify clinically whether or not that would even fit. So here's another, it's kind of large surfactant granules. And then I also wanted to make the point that this was a case of ABCA3 deficiency. And you can see many of these appear normal. And so it's very true with these surfactant granules that you will see some normal looking surfactant granules. It's very unusual for them all to be malformed or abnormal. So EM can also play a valuable role in evaluating the interstitium, and interstitial lung disease comes up a lot in pediatrics also. In this case, it's demonstrating that by light microscopy, this interstitium would appear thickened, maybe a little pale, and by EM we can show that this is collagen. There's a fibrosis, interstitial fibrosis, that's expanding that interstitium. And in this example, interstitium is expanded by an inflammatory cell infiltrate. We don't really need an electron microscope, but it's good to be able to recognize if there is an inflammatory cell infiltrate there. Infectious process can be identified here by actually seeing the organisms. And kind of current events here. This was a case we had of hantavirus infection here in the endothelial cell, and I'll show up some bigger pictures there. I promise you don't have to squint. So here's a couple of viral particles, and this was a case of suspected hantavirus pneumonia, and we were able to find a few of these viral organisms here. What we do most often with these is try to identify or confirm pulmonary interstitial glycogenosis, or PIG. It's usually a fairly benign condition. I think Dr. Galambos on Thursday is going to be talking to us more about this. We've identified many more conditions that kind of lead us to believe that maybe it's not as benign as what we thought. We were finding these PIG cells in many different disease processes, and usually they just a course of steroids can improve the patient's outcome. But you really need an electron microscope to be able to confirm that's what we are, and that's what we're seeing. And so what we're looking at here's a little bit of the interstitium. We see the capillaries, type 2 cells. In pulmonary interstitial glycogenosis, there's a thickening of that interstitium by these pale, spindly cells that you can see by light microscopy. And they're pale because on the inside their cytoplasm is a diffuse accumulation of the monoparticulate glycogen. And it's important to know the difference between the types of glycogen that you're looking at, because in the type 2 cells, which you can see over here by this one that has the surfactant granule in it, they normally will have polyparticulate glycogen. That's just a normal component. However, the PIG cells contain monoparticulate glycogen. And so seeing these cells, that's an indicator of PIG, and pathologists like to put that in report or confirm that that's what they're seeing when they see these kind of the pale expanded interstitium, these distal lung biopsies. So that's that. I'm gonna move on now also for respiratory disease. We'll be talking a little bit more about this on Wednesday, but I wanted to give just kind of take a step back and just kind of review cilia ultrastructure, especially in the setting of primary ciliary dyskinesia. So this is an image of also obviously a false color image of cilia that's protruding from the epithelial, from a respiratory epithelial cell. You can see the cilia rising up above the microvilli that are also protruding from there. The cilia are much wider and much taller than the microvilli. And in this kind of longitudinal section of the cilia, you can really imagine this wave pattern. These cilia have to all beat in sync, and so you can almost see the movement there. But the cilia is basically what's moving the mucus up through the airways, removing all the pathogens and any kind of toxins that had been inhaled or anything. And so if the cilia don't work, that mucus stays put. And that creates chronic infection, chronic inflammation, can lead to bronchiectasis, which is the main morbidity of primary ciliary dyskinesia. It's very similar, present very similar to cystic fibrosis, which of course in the cystic fibrosis, it's the mucus is too thick. It's too thicky. So the cilia work right, but they just can't move the mucus. In primary ciliary dyskinesia, the mucus is okay, but the cilia aren't working. The ultimate thing is the mucus stays put. And so it can have very similar symptoms. Difference is because the mucus in PCD is normal mucus, these patients can cough and they can move that mucus through coughing where cystic fibrosis patients cannot. This is the scanning electron microscope image of this is the tracheal biopsy. You see, not all the cells are ciliated. Some of them are, but not all of them. These kind of grainy looking ones, these are just the microvilli and those epithelial cells, but lots of cilia here. And just kind of showing cross section of cilia and microvilli together. Here it's pretty obvious to see the difference, especially if you know the diameters that you're looking at. A cilium is 150 nanometers in diameter. Microvilli, of course, are much smaller. If you have one of those cells, though, without cilia, and you're just looking at cross sections of microvilli, and you're not exactly sure what size you're at, what magnification you're at, you might think, could these be cilia? That something's wrong with them if you don't know. So put that out there every now and then just to remind people that of the kind of the field of view that we need to be working at. So the normal cilia motion, people have described it as kind of a swimmer stroke, where the cilia kind of reaches up into that mucus, all of them together, push it forward, push it up the airways, and then it kind of retracts down through the less viscous. There's a much less viscous layer, mucus layer that's just right above the epithelial cells. And so the cilia can retract without bringing the mucus back, kind of raise back up, push the mucus forward. So this happens, 100,000 times to keep the mucociliary clearance system working correctly. If the cilia aren't working, you can end up with no motion. So this would be just kind of a stiff, no motion. In fact, PCD initially was called immotile cilia syndrome because we thought that the cilia either worked or they didn't. But we know now that that's not the case. We can have more of a stiff motion where there is some movement, but not enough to effectively clear that mucus. And it's for this reason why the doesn't happen so much anymore. I'm sure it's happening in some places, but it used to be that after a biopsy, you could look at the cells under live cells underneath a light microscope. And if you saw cilia beating, you'd say, oh, well, the cilia are moving, so the patient doesn't have PCD. But to really analyze this, you have to set up cameras, top-down cameras, side view cameras, and where you can measure the beat frequency and the beat pattern to make sure that these cilia are beating in the right direction and with the right frequency, because you can't have this sort of stiff motion. And then there's also kind of a circular flailing motion if there's some structural defects within the cilia where the cilia just spin around in circle, and that doesn't do any good either. And so just a couple drawings to show kind of what we're dealing with. I like this one because it actually shows the cilium all the way down into the cell cytoplasm. Kind of at the base of the cilia is a basal body, which is essentially just a centriole. The way ciliogenesis happens is the centrioles multiply, and then they migrate up to the apical surface of those cells, and then the cilia extend through within a specialized ciliary membrane. And but at all these different levels, so each one of these cross sections are from a different level of the cilium. So if you're looking at the basal body, this is what it's going to look like. We have instead of doublets, the 9+2 doublets like we like to see. There's actually triplets, and there's no central pairs here. And then there's kind of a transition zone where they become doublets, but there's no central pairs yet. And then it's not until you get up here into this kind of normal 9+2 axonemal region where you can even expect to find normal morphology. So, but fortunately, this isn't really to scale, and this area is much longer. So most of the cilia that we get are in this nice 9+2 region. But it's important to be able to recognize if you see something that looks like this, it could just be that you're just above the cell surface and you haven't really moved into that normal 9+2 area. This is some of the micrographs just kind of showing that. So here's the epithelial cell edge. So here's our basal bodies lined up here, and then we're kind of transitioning all the way. And it's not until we get all the way out here that we actually see this normal 9+2 organization. Some little bit higher magnification views of this. Here's within the cytoplasm, you can see the triplets, microtubule triplets. It kind of forms this nice kind of Star of David pattern there in the middle. And then just when the cilia exit the cell, it looks like they're connected. There's two. There's peripheral doublets now, but still no central pair. Here's one central microtubule that has appeared. And then as we move farther out, the central pairs are there, and then we end up in kind of in this mid-axoneme compartment where we have the normal 9+2 organization. And then at the tip, I didn't point out on that drawing, but the very tip of the cilia is conical shaped, and that drawing showed that all of those structural components kind of ended at the same time, but that doesn't happen. They kind of fade out individually, and you can see some different kind of structures. So seeing something like this, especially when the diameter is smaller than a normal cilium diameter, you can be certain that you're dealing with just that conical, I call it the tip artifact, where you just shouldn't expect to see the normal organization. So what can go wrong with cilia? Well, this has been fascinating disease process for me to study. I put this list together here of all the different genes that can cause PCD, and they are almost all autosomal recessive, found on many different chromosomes, unlike cystic fibrosis, right? And the interesting thing is that we know what these genes code. And there's a very strong genotype-phenotype relationship with PCD. And so, for example, these are sorted by the percentage of PCD cases. So the most common cause of PCD is a mutation in this DNAH5 mutation that was first reported in 2002. And that's an outer dynean arm defect. So this is ODA, stands for the outer dynean arms. We'll talk a little bit more about that. And then you can kind of see as these are sorted. And I put the years on here because it's kind of interesting. I took one slide out because I was afraid it's going to be too long. But there was a big spike when next-gen sequencing came out, and they identified a lot of these novel mutations. But most of them contributed very, very little to the overall number of PCD cases. And that's still true. I think there's about 40 genes here. We're up to about 59 now, but the 19 new ones since I put this chart together contribute very little. And so for that reason, back when next-gen sequencing first came out, everyone thought we're not going to need EM to diagnose PCD anymore because we're going to have a genetic panel. We can just do genetic testing. Still today, genetic testing can only identify 70% of PCD cases. And so EM can also identify 70% of PCD cases. And the reason why is because of our number 2 contributor to PCD is this DNAH11 gene. And biallelic mutations in this gene cause PCD with no ultrastructural changes whatsoever. The cilia look completely normal. And so for this reason, and we'll get into more of this on Wednesday, there's not a single test that can completely exclude PCD. TEM can't do it. Genetics can't do it. It takes a multimodal approach to make this diagnosis. Some of the other things, MTD, this stands for microtubular disorganization. I'll show you what that looks like here in just a minute. So on this, here's our conventional 2D image. So we had talked about the microtubules and the doublets and the central pair. Those are the structural proteins. The motor proteins that actually make the cilia beat are the dynein arms. So these are the dynein motor proteins, and they look like little hooks coming off of these. And so while if you think of this as being kind of like a coaxial cable coming out of the screen at you, the dynein arms are just little hooks. They're not continuous like the microtubules are. And there's the functional unit, I guess, of the cilia repeats every 96 nanometers, which is important because how thick are our slides that we're looking at? Sometimes about 96 nanometers. So there could be within our ultra thin sections that we're looking at on the TEM, we might not even have all of these dynein proteins because they're just kind of hooks. And I'll point out also that the outer dynein arms are always easier to visualize. And for that reason, but we still only need to see an average of 7. That's when we did the math, and you need to average 7 outer dynein arms for it to be normal. The inner dynein arms is a smaller protein complex that's spaced farther apart on those doublets, and so we don't always see them even if we're there. But for it to be abnormal, we need to see. For it to be normal, we only need to see an average of 3 inner dynein arms per cilium. Talk more about that later also. So going back a little bit more, so kind of reiterating what we talked about earlier. So here's some drawings. This is from a paper, by the way, that came out in 2020 by Amelia Schumark and mainly our European colleagues. That really it was a long overdue paper that helped us define how do you write an EM report and what needs to be in the EM report when you're looking at these PCD cases. And so that's where these images came from. And so again, we have down inside the cell, here's our normal axoneme, and then kind of the tip artifact that you can see, also shown here from their paper. There's what this paper did was define the TEM defects as class 1 and class 2. Class 1 defects are the hallmark TEM defects, where if you see these defects, you can diagnose PCD. But it's very specific what it is that what you have to see to do that. And so that's limited to a complete, or this is an outer dynein arm deficiency. Here in the cartoon, you can see the inner dynein arms are here, but we're missing the outer dynein arms. And this is what it would look like by TEM. You can see, again, you only need to see an average of 3 inner dynein arms to be normal, but you can hopefully appreciate that the outer dynein arms are completely absent here. The second hallmark class 1 TEM defect is a complete dynein deficiency, represented here in their images from the paper. And then this would be the microtubular disorganization. This is with an absence of inner dynein arms. So this is really the only instance that I ever even comment on whether or not the inner dynein arms are present or absent or there. It's if you also see this microtubular disorganization. So here you can see the doublets are just disorganized. And I'm waiting. I'm surprised it hasn't happened yet, but so far from that list of all the genes, all the mutations associated with PCD, not a single one of them is just an inner dynein arm defect. We have just outer dynein arm defects, but all the inner dynein arm defects have to do with the biology of the inner dynein arms are related to the radial spokes. I didn't mention the radial spokes, but those are these radial spokes kind of coming out from the center, kind of keep everything out at the periphery. And that relationship, if there's a microtubular disorganization with an inner dynein arm loss, that's what you end up with, is this microtubular disorganization. So this is some of our images and kind of what they look like. So this would be a total outer dynein arm and inner dynein arm defect. This, if you see this, and again, you have to consider the percentages. So, and we'll talk more about this, but to be diagnostic, you need to have at least 50% of the cilia need to look like this. If you see that in 50% of the cilia, you can call it PCD. If it's 25 to 50%, that will change things. Here's a partial outer dynein arm deficiency. Again, these dynein arms is a long protein complex, actually a pretty large, long protein complex with 20 or so proteins in it. And so a mutation in any of those genes that form any of those proteins, you might have no outer dynein arms, or you might have what we call kind of a stubby arm variant, which you can, maybe it's my next slide here that, no, this is you might be able to appreciate some just kind of stubby arms coming off of here, but certainly not full outer dynein arms. And to be a full outer dynein arm, you really need to see a curve almost. And the way it works, I didn't get into this, but I'll go back to, sorry, normal one. So on the normal cilia, so these dynein proteins actually piggyback on the doublet that's adjacent to them. And there's been some amazing movies that have been made where they show these dynein arms kind of walking up the adjacent doublets. And then on the opposite side of the cilium, they'll be walking down. And so that caused the cilia to beat. And so that's how they move in concert like that. And so if a short outer dynein arm will reduce, that's usually what kind of that stiff motion is, where we have some cilia movement, but not the full movement. That's usually because it's just a partial outer dynein arm. Let me get back up here. So this is a classic case of this IDA, interdynein arm deficiency with microtubular disarray. These are exclusively, well, I'll say exclusively, but CCDC39 and CCDC40 mutations will cause this. But let me move on here. There are a couple of caveats here, which can move things down to class 2 defects. Now, a class 2 TDM defect is not diagnostic for PCD, but it can be provide supportive evidence for PCD. So if we see some of these class 2 defects, that's what we call it. We recommend that they perform either another biopsy so we can look to see. And the reason why these are class 2 is because these features here, an absence of the central tubules, when you're in that 9+2 area where you should see the central tubules, if those are absent, or they can be absent, and then this is what we call a transposition defect, where one of the outer doublets kind of migrates into the center. So if you were to count these, this is a doublet, and the difference is you can see the doublets have kind of an alpha and beta tubule that piggyback on each other. The central pair are two distinct microtubules. Sometimes you can have more than one pair. And then here we have just a single central microtubule. So these have a lot of overlap with just secondary reactive changes to the inflammation or infection or whatever might be happening. And so for that reason, but they also could be PCD. There's genetic mutations that can cause this, but because there's that overlap, these have been kind of downgraded as class 2 evidence for PCD. And so so it can support the genetic findings. Are kind of inconclusive. If there's only one variant and maybe one VUS, but we see some of these, then that might be enough to call it PCD. But the class 2 defects, it's important to let the clinicians know are not diagnostic for PCD. This is what some of those can look like. So here's a central apparatus, absent central apparatus, which is kind of the central pair, and it's sheath with the transposition. So you can see these peripheral doublets have migrated into the center. And then this is from a patient with that DNA H11 mutation where the cilia ultrastructurally are completely normal. And they've actually worked out how that works, where with some of the immunofluorescence staining and some of the other stuff that we can do, the proteins that are supposed to be there are absent, but then they're replaced by some other proteins downstream. So visually, but they don't function right. And so they look normal, but they're just not functional. And so this would be kind of the normal cilia in a patient with PCD. as an electron microscopist, when you're screening these things, one of the most important things we can do is be able to identify what is primary change versus secondary changes. Primary in this sentence has a couple of different meanings. When we're talking about primary ciliary dyskinesia, we're talking about a genetic cause, right? And so but there's also, you might have heard of primary cilia, just plain old primary cilia. Those are cilia that you might find in kidney biopsies or many other, pretty much every cell at some point has a primary cilium, which is really more of a sensory cilium. Anyway, when we're talking about this, so primary changes are congenital, they're permanent or universal. It wouldn't matter where the biopsy is, all the cilia are going to show the same thing. You can do another biopsy later, and that's you'll still see the same defect, and it's something that patients are born with. Whereas in secondary changes, oftentimes these are local at sites of infection or inflammation. It can be temporary, and the biopsy later on will show normal cilia, and it's not something that the patient was born with. So some of these kind of secondary changes to be on the lookout for. In this field of view, we can see most of these, you can take my word for it, I mean, you can't see them all, but these are almost all completely normal cilia, except for this one in here that has a couple extra central pairs and or central microtubules. And so, one cilium, you have to see at least 25% of these to even be suspicious or even get close to calling it a class 2 defect. Yeah. One of the most common things that we see is the formation of these compound cilia. So here we have multiple cilia axonemes, which is the whole structural component surrounded by one ciliary membrane. These are produced when these epithelial cells are recovering from injury. And so that usually those cells will drop all their cilia, and then there's kind of a mass regeneration of cilia that's kind of out of sync. And so you end up with these axonemes that are all surrounded by one single ciliary membrane. Very common, completely nonspecific. And then we can also see just an absence, ciliary aplasia was something that can happen, ciliogenesis problems, where you have nice epithelial border. We have some microvilli, kind of ratty looking microvilli, but down underneath we have inflammation here. And so when you see a lot of inflammation, we encourage all of our clinicians who are performing these biopsies not to obtain the biopsy from a site that is obviously inflamed. And we prefer for the patients to have been in at least a decent state of health for a couple of weeks before they collect the tissue. Problem is, the patient has PCD. They're chronically sick. They're chronically, have the mucociliary problems, and so it's not really fair for us to tell them to only biopsy patients when they're healthy, when they're probably never really that healthy, right? But that can happen, and then. And then this can eventually develop into kind of a squamous metaplasia. And so oftentimes we end up with these ciliary biopsies where we're just looking at squamous metaplasia and none of those cells are ciliated. So we'll be talking a little bit more about that. They just came out with a new guideline. I think one of the most interesting kind of, I don't know what to call it, the discussions over the past decade or so has been between the American Respiratory Society and or the American Thoracic Society and the European Respiratory Society. They had both looked at PCD and to come up with some clinical guidelines for making a diagnosis of PCD, all evidence-based, and came up with completely different recommendations on how to approach it. And there's been some very good pro-con kind of arguments in the literature that have been kind of interesting to follow. But finally, the two groups got together and came up with a joint guideline. And that was just published at the end of last year. And I'll be kind of summarizing that because it kind of changes a little bit what our role is as electron microscopists in dealing with this disease. How much time do I have? You know what? Not much. I might have to save this for another day. What, 5 minutes? Probably not 5 minutes. Which is okay because I know I know Dr. Howell's going to have a nice talk about lysosomal storage disorders for us later. This is part of our, maybe I'll just go through some of it. We're not going to read all of this. This is just all the things that can cause storage disorders. If you guys are okay, I'll just kind of go through, this is kind of like an atlas anyway. You guys will have access to all of these, but these are just kind of images of things that you can see in different kinds of storage disorders. I will point out as it's important to make these diagnoses as early as possible. That's when, whatever kind of therapeutic measure that we're going to take can be most effective. These are all the different specimen sources that we've received to try to identify metabolic storage diseases. The ones that are kind of bolded and capitalized are the most common ones that we've looked at. I didn't know really how to organize this, so we're going in alphabetical order. We'll see how close I can get to Z by the time it's lunchtime. But we already talked about alpha-1 antitrypsin. Put this in here again just to emphasize that not all metabolic storage diseases result in a lysosomal storage disease, right? Sometimes it's non-lysosomal, as in alpha-1 accumulating in the rough endoplasmic reticulum here. Cholesterol storage disease or Wolman storage disease. These are cholesterol clefts that are accumulating in the liver hepatocyte. Usually, kind of like one bad cilia doesn't make PCD, one unusual looking lysosome or accumulation of something doesn't make a metabolic storage disease. This is one case that was a little bit contrary to that. It was suspected, and we had to cut multiple blocks to find those. Cystinosis in the kidney tubules is quite distinctive. These are the kind of images you see in the textbooks. I wouldn't hold out for looking for these perfectly, kind of rhomboid shaped crystals. A lot of times they can be a lot more flattened and not quite as obvious as that. Danon disease and related entities, different kinds of vacuolar myopathies. You can find the inclusions here that you can see actually represent sites of cytoplasmic degradation that's resulting from the weakened membranes of the lysosomes. And so the lysosomal content spills out into the cytoplasm and causes necrosis. I bet we're going to have a talk about Fabry's disease. We usually do here. Should be able to recognize this, hopefully from your semi-thin sections. These just are beautiful on our either our azure blue or toluidine blue sections. Accumulation here in the podocytes. This is what they usually kind of look like for us. Here's another case of Fabry's disease from the skin. Here, I think this is just differences in the fixation. That sort of thing can cause these to look a little bit different. And as we go through this, you're going to see that, if you're using these images as an atlas, don't expect them all to look exactly like this. That just doesn't happen in especially in metabolic storage diseases. This was a case where EM suggested a diagnosis for a really puzzling case. It's a very rare disease. I don't know. Anyone seen a case of Farber disease? It's literally like 1 in a million case that results in the accumulation of ceramide in these lysosomes. Oftentimes, this is diagnosed in children as juvenile idiopathic arthritis because there's swelling and a lot of joint pain. So the patients kind of clinically get that diagnosis. That didn't really fit. And when we got this, we said, this looks like a lysosomal storage disease. We weren't able to put a name on it, but we were able to let them know that there was something else going on. In this instance, there was a clinical concern directed about this is muscle biopsy where they were suspicious of a mitochondriopathy. Again, mitochondria looked fine. It didn't look like mitochondriopathy, but you can see here in these endothelial cells, these many clear lysosomes. And this is when they look this clear, you can kind of guess that this is what an oligosaccharide would look like inside of a lysosome. And so we didn't give them a diagnosis, but we told them it's not a mitochondriopathy. You need to kind of go down the metabolic route and see what you can find. And this ended up being fucoidosis. Gaucher disease, we should all be familiar with Gaucher disease. It's fairly common. In here, it's identifiable by these twisted kind of membranes within these lysosomes. These are real kind of spiculated lysosomes with this twisted kind of tissue paper look to the content. And Gaucher's disease. So lunchtime? Maybe I'll stop here. What do you think? Should we go through or G? So lunchtime? Yeah. Keep going? All right, we can keep going a little bit. So glycogen storage disease is, I got one, keep going. That's all I needed. We have glycogen storage disease. There's lots of different, there's 9 or 10, maybe even more now of glycogen storage disease. EM can confidently identify 2 of them for sure. One of those is type 2, which is Pompe's disease. This is where glycogen accumulates within these lysosomal membranes. Sometimes these membranes can break and the glycogen kind of spills out, so you can see an excess of in the cytoplasm and the myocytes, but you'll always see glycogen within some membrane-bound structures. The other type that EM can recognize is type 4, Anderson's disease. This is where the glycogen itself is malformed. You get this fibrillary form of glycogen, and that's what that would look like by EM in a muscle biopsy. And this was a child that was suspected of having a glycogen storage disease. And one of the big clues is that in these hepatocytes, if there's too much glycogen, we'll see the organelles all pushed out to the periphery. This excess glycogen will either push things up close to the nucleus or out to the periphery of the cell. And here we have some glycogenated nuclei, a little bit of fat. And so this looks like a glycogen storage disease. It doesn't look like type 2, doesn't look like type 4. Not all glycogen storage disease affect all tissues the same either. And so of the glycogen storage diseases that affect the liver, only 2 of them reliably have glycogenated nuclei also. And those are type 1 and type 3. And then, but looking at the fat in type 3, the fat tends to be mostly microvesicular, whereas in type 1, the fat tends to be macrovesicular. And so we can't be certain, but usually if you tell the clinician that this looks like a glycogen storage disease, they're going to do some testing and be able to identify it. But we can give them a pretty good guess, and we were right this time, that this ended up being a type 3 glycogen storage disease. This is Krabbe disease. We don't get brain biopsies very often from living patients, but from autopsy we can identify this globoid cell leukodystrophy is another name for Krabbe disease. And these structures here can look similar to the Gaucher's inclusions, but context and site and everything, that you're not likely to confuse those. Before disease here, this is a patient, as a 14-year-old boy who had a head injury after diving into a pool and started having seizures. And they thought that that didn't really fit clinically what was going on. They thought that it might have been triggered also by some kind of metabolic storage problem rather than a traumatic injury. And so in this case, these are the Lafora bodies that you can see. And we got a skin biopsy here, which is what we usually prefer. If we have a choice, we prefer a skin biopsy because these inclusions first appear in the basal layer of the sweat glands. And so if you get some other tissue type that doesn't have the sweat glands, we would have missed this diagnosis here. And then like we were talking earlier about partnering with our biochemist, and this was a case where the biochemistry suggested that this patient might have 2 completely different metabolic storage diseases, which would be really, really unusual. These are all really rare diseases, right? But it looked like they might have had beta monoacidosis and Sanfilippo disease, which is this is a mucopolysaccharidosis type 3A is Sanfilippo disease. And so they gave us a piece of tissue to look at, and sure enough, there's 2 very different inclusions that are going on here. Here you can see, let's see, higher magnification here. So these are the hepatocytes, and these have the inclusions that are more consistent with the oligosaccharidoses or the anamyloidosis. And then here in the histiocytes, there's inclusions that are more consistent with the mucopolysaccharidosis. And so we're able to confirm that indeed the biochemistry was right, and this patient does have two different storage diseases. And then again, to emphasize that you don't usually have to look too hard to recognize that something's going wrong in these cases. And this is a case of mucopolysaccharidosis type 1 or Hurler's disease. And again, bear in mind that these are all different kind of mucopolysaccharidoses that have a different kind of looking morphology, but they can vary from even within the same case what these inclusions look like. Mucolipidosis, I'm going to go on through here. I think Dr. Hicks later is going to be talking about what we can see in some of the blood cells. So I'm going to skip through the CLN disease or neuronal cellular lipofuscinosis. We used to get a lot of biopsies for these, but these are pretty much all diagnosed by genetics now. So we're not getting nearly as many of these, but there's different kinds of lysosomal inclusions for the different types of CLN disease now is what we call it. Niemann-Pick disease type C, this comes up a lot as well. You want to be able to rule that out. It looks a lot like some of those earlier liver images that I was showing where we had bile accumulation and this focal cytoplasmic necrosis. But in this case, this is the sphingomyelin that's accumulating in Niemann-Pick disease. And importantly, and a way to kind of distinguish that, if you're not sure, especially in early on in the disease process, when there's not a ton of these inclusions, the Kupffer cells in Niemann-Pick type C disease are much more affected than the hepatocytes, where if it was a cholestatic process, the hepatocytes would be more affected than the Kupffer cells. So keeping an eye out and knowing what cell types you're looking at is important. We're getting to T. Tangiers disease. As mentioned before, we talked about Tangiers. I'm going to skip that one. Tangiers disease. And now Z, back to the peroxisomes and the Zellweger spectrum. So we already talked about this, where there's either an absence or malformed peroxisomes creating these trilaminar leaflets within the lysosomes. So I will stop there.